Hi, my name is Corey Hesden. I am 29 years old. I live in Virginia, and I will tell you about a time that I stayed in the hospital overnight. Thankfully, the nurse was there that night from the night before when they sent me home. So that nurse was like, no, she was her last night. She's having contractions. Let's take care of her, please. So thankful to that nurse still today.
Welcome back, Health Impact audience. We're going to have a really lively discussion here today about connecting physicians, pharmacists, patients, and how we can actually combine all of them to build stronger, more collaborative relationships. And we've heard a lot in the last few years about this idea that people should be operating at the top of their license. While that's not going to be the cornerstone of our discussion here with Mark, it's going to come up a few times. And what you're going to learn over the next 15 to 20 minutes as we talk to Mark is you can use pharmacists, you can use others to do all the hard work that is necessary to do collaboration with patients in value-based care. So with that, Mark, tell us a little bit about yourself. I know you've spent some time in government circles as well. So give us a little bit of your background and what you learned at your time at CMS.
Well, thanks, Shahid. It's a pleasure to be here with you all. I'm looking forward to the panel conversation after this. I'll start with a story about my background. I was in my final year of medical school, and I was just as optimistic about the potential for value-based care as I am today. And I remember sitting down with my medical school dean to talk about my options after graduating. And when I said I wanted to pursue this thing about value-based care and be a physician architect of the system, two things happened. Number one, the biggest deer in the headlights look that I've ever seen. And then number two, a quick trip to the psychiatrist to make sure that I knew what I was getting myself into. I'm glad I continued down that path, and I'm glad the country is still solidly on a path toward recognizing and realizing the promise of value-based care. I think we still have a long ways to go, particularly in the areas of shared savings and recognizing the investments upfront that are made for that transition into value-based care. But I'm excited to continue on this journey as the Chief Quality Officer at UpStream Health, which is a rapidly growing primary care solution. And UpStream, and what made me leave CMS, which was a wonderful time in my career working on leading some health policy changes as we were looking at the 10-year history of the CMS Innovation Center, charting the next course, the next decade for healthcare policy out of the Innovation Center, including a focus on health equity and prospective reviews of quality metrics, but then also on the bundled payment program and how we're structuring the intersection between primary and specialty care at the payment level. But what drove me to leave CMMI was really this exciting opportunity to join the UpStream team, because I felt that the different approach that was using embedded clinical teams, including clinically prescribing pharmacists, to help physicians more effectively enter primary care was exciting, and it wasn't something that I had seen in other places in the market. Certainly there are places that will assist you with the technology and with the financial portions, but I think it's that trifecta and the three-legged stool of having the clinical, financial, and the technology. So looking forward to getting into the conversation, Shahid.
No, that's great. And I love it when people spend time at the government where they can both influence policy as well as see what's going on in the broader landscape. But then coming out into industry, you realize how hard it is to actually implement most of the policies that you came up with. Anything that as you're coming into UpStream, leaving CMMI, what puts you at more ease to say, hey, some of the stuff that CMMI is doing makes things easier? But how would you look back maybe to your days there to say, you know what, it would have been better for us to give more input to the industry with X, or don't be as prescriptive and let the industry give you. So just give us your time there and what you learned there that now you can apply over at UpStream as well.
I've been incredibly impressed by the speed at which the health equity focus has been distributed out throughout the market. I think we're seeing a focus in participation in the ACO REACH, which is the new direct contracting program, and that forced focus on health equity to be catalyzing a movement that we're seeing across other commercial payers, health provider organizations, health systems, even all the way down to independent primary care practices. So I have to say that it warms my heart to come out of CMS and see some of the work that we were starting just as I was leaving on health equity being quickly adopted by the market and very effectively adopted. And I think that's an important step forward for the country. When I think about advice that I might give myself a year or two before, I look at some of the challenges, back to some earlier points around finances. I think that we still have yet to solve at the programmatic level or the contracting level how we appropriately reimburse in the right time period for these investments in value-based care. Some of this is due to technology. We don't have the data at the right time, at the right point of care to be able to appropriately reimburse or drive incentives at that real-time level. We're waiting 18 months, and at that point, it's maybe money. We've heard shared savings described as maybe money. And I think as we continue to mature, I would push and encourage my former colleagues who are still driving incredible progress at CMS to continue to think about how we get more real-time access to data that can shape those payment models that would reimburse in a real time or line up those incentives more effectively with the work that's being done.
That's right. And I've heard the same calls to action basically from CMS to say, hey, we need more data. We have to get to more real-time data. The problem has been, so partially technology oriented, but partially even between the technologists, whether you're talking about the CIO or the chief clinical officers, et cetera, they're not actually sure what value-based care means, right? There's no common definition that says, okay, if you do these 19 things, you are value-based care. And if you miss 3 of them, you're no longer value-based care. So who do you believe out in the industry, and this is not it's not a CMMI view of the world, just based on what you see in the industry, who's doing value-based care, quote, right? And what does that mean to do value-based care right?
The folks that are doing value-based care right are those who appreciate that the hard work has to be done using humans. This is healthcare remains a human face-to-face or telephonic relationship-based industry. And I think when we recognize that at the end of the day, value-based care is a way and a mechanism for us to be reimbursed and to create the correct system to allow someone at the point of care to build a strong relationship with the patient, help guide them, lead them to independent decision-making, independence in their healthcare outcomes, and focus on their own goals and realizing their health goals to live a longer, healthier, and more supported life. And I think that when we orient technology around that, the financial model around that, the payment system around that, then I think we get to good outcomes. So when I look at some of the greats of the world in the value-based care setting, the Oaks, the Chens, the Ioras, I think that they appreciate that at the end of the day, there's a strong relationship with the patient. And at UpStream, that's been our focus. We spend an inordinate amount of time teaching narrative therapy, teaching psychodynamics of interacting with patients to be able to build those strong relationships, because we realize that it's the relationships with the patients, the relationships with the primary care office that make the healthcare system successful. And when we can get the waste out of the system and then focus on those relationships, I think we're in a pretty good spot.
Nice. So as you think about talking with potential customers, partners, and those groups of folks where you could say, hey, when you get started or very serious now about value-based care, here are the things that you need to do. And I love the idea that a technology enabled with services solution is probably the only way to go. Like I've been in the healthcare world for a long time, multi-stage entrepreneur as well. So I've started multiple companies, and I don't think there are a whole lot of super successful, pure tech play companies in healthcare. Super opinionated, but easy to defend. And that is because it's still human labor that gets all the work done. So as you walk into customers, what do you often see either in their strategy or their implementations, and you say, oh, I can see why all the shared savings you're trying to achieve are not being achieved, or I can see why all these strategies that you are trying to implement are not going to really help you much. Like, as you walk into customers, what would you say to them in a common area to say what they might not be doing in order to get to value-based care properly?
Mhm. I go back to, I was raised by a large family of physicians, and I can tell you not a single one of them was ever trained in how to take a list that came out of some fancy analytics tool and run through that list and close healthcare gaps. That's not how physicians are trained, and I've yet to meet a physician that wants to work in that way. Where we see opportunities is when the physicians understand that they can be that architect of that system. They can retain those relationships and build stronger relationships with their patients, but embrace a team-based approach that pulls in other disciplines like clinically prescribing pharmacists, coordinated registered nurses, health concierges, others call them health coaches, or other allied health professionals. That team-based approach and delegating the work appropriately, I think, is where we see those quickest and earliest gains. But before we can even get there, oftentimes it's challenging to get data and historical data. So we'll rely on data partners to help us aggregate what the quality performance has been across that network. And it's challenging. You might have 18 different practice sites, and you might think you have 4 or 5 different EMRs in total, but those 4 or 5 different EMRs might have different versions and they might not talk to one another. And so now all of a sudden this getting data from 4 separate EMRs becomes getting data from 18 separate EMRs, and pulling that together to be able to understand that baseline is pretty challenging sometimes. So when we start with a conversation with someone and hear that they already understand where their quality performance stands and where they've been sitting on shared savings performance, whether that's positive or neutral or negative, I think we're already a step ahead in being able to understand what's next and what sort of clinical model, technology, and services makes sense to continue to see those gains in value-based care.
So those of us that have seen value-based care programs implemented in a variety of different states, is there a commonality of those that you've seen where outsourcing, partnering for the value-based care part of what a healthcare delivery organization does versus the fee-for-service? Is there a strategy that says, you know what, we're good at fee-for-service, we'll just handle it, and I'm just going to hire Mark at UpStream to come in and do all my value-based care? Is that a reasonable way to set up your strategy for a healthcare delivery organization? Or when you get into value-based care, you better be all in or just stay all out? How would you react to that strategy suggestion?
I think you can be moderately successful if you retain a fee-for-service panel, but to fully recognize the potential and where I think we should be headed as a country, we need to have practices full in on value-based care. I think it's absolutely achievable to hit quality measures, be delivering high quality care to patients with one foot in the fee-for-service door and 1 foot in the value-based care door. But when it comes to recognizing the real performance around utilization reduction for unnecessary and often traumatic visits to the ER, to the acute care facilities for your patients, we have to have a unified approach at the practice level. And that's challenging and unreimbursed in that fee-for-service world. And so if you want to be able to flip the switch on some sort of new intervention to provide home care services or ED diversion programs or community paramedicine, you can't afford that if it's only a percentage of the population that has those revenue streams to be able to support those new services. So I think maybe there's a period of time that you can get by, but I'm not sure if it's a long-term solution.
Yeah, that sounds exactly right. And so as you start to look at coming in to help customers, where do you like to start? All right. So let's say that I'm the CEO of a healthcare delivery organization, and I've said, look, I want to be in value-based care and I'm serious about it. We'd love to hire UpStream as a partner. What do you come in and do that I couldn't do on my own?
So we start with a few things. If you're running an ACO today, you have full risk contracts. I think you're asking yourself a few questions right now. You're saying, how do I retain high quality physicians and providers within my network in the face of the Great Resignation and in the face of increasing pressures on new entities that are gobbling up high quality physicians? And you have to have a solution to be able to maintain that network integrity and those high performing docs. You're also thinking, how do I manage increasing utilization in the setting of COVID? And then you're also looking at the regulatory burdens of new programs and new regulatory updates. And so I think what we usually start with are where is the state of the ACO? And is it a place where you're seeing significant shared savings already and we're optimizing the system and retaining and baking in those gains? Or are you on the lower end of the shared savings spectrum? You haven't quite seen the returns from the investment in value-based care, and it's time to really double down on the clinical model, on the staff interventions, and retaining perhaps a network that's looking for opportunities and financial incentives that may be greater in participation in other ACOs. And so what we do is we usually start with an overview. I think what is different about UpStream is we've pioneered a model of guaranteed advance payments for quality. And so we pay on a monthly basis based on quality scores on a rolling 12-month basis. And so it converts from an 18-month shared savings cycle into a monthly payment mechanism that covers the cost of the investments in the value-based care and recognizes physicians for their partnership in that work. And then once we get through that, the payment model mechanisms and the clinical model, then we deploy those clinical staff, and we actually take a clinically prescribing pharmacist out to the practice sites, and they interview with the local physicians, and then they build that collaborative relationship. And I think what's interesting, and I have to admit, I hadn't totally appreciated the role of pharmacists until joining UpStream. For those who are less familiar, as I was, in most states, there's a provision for clinically prescribing or clinical practice pharmacists, which actually enables most pharmacists to be able to initiate pharmacotherapy, refill medications, entertain a full pharmacotherapeutic workup, and partner very closely with that primary care physician. And so what we see in really high performing practices across the country that have used pretty progressive practices that have used these pharmacists well, they're seeing that they'll make that diagnosis and then they'll pass the patient off to their the practice's pharmacist. And that pharmacist can have hours-long encounters with the patient to build a strong relationship, weekly medication calls to ensure adherence to the diabetes medication, to high blood pressure medication, et cetera. And that partnership between the practice and the patient becomes very strong and very powerful. And so I would encourage folks to look into those models. I think that they're transformative if delivered appropriately.
No, I love that model. In fact, when you think about the totality of licensed professionals, for sure, pharmacists are very underutilized for how much they know, how much they go to school for. It would be like asking doctors to only do half the job, right? So I think there's a lot of stuff that pharmacists can do because good doctors already called them up and to ask them about medications, et cetera. So it's almost like one of those obvious things that you would do, but it took companies like UpStream to actually pick that out and say, you know what, maybe we can use these guys. So love that model. And in fact, we should try to double down on those. So in the last couple of minutes before we turn it over to our panel to extend this conversation, talk about what kinds of companies do you think are ripe for UpStream to work with versus those that might be too early, or they may not be able to help as much. Who are some of your best fitting customers that you'd be saying, hey, if you're in this space doing X, Y, and Z, call us because we can take you to the next level pretty quickly.
We're excited about practices and ACOs that have experience with full risk contracts, that have either line of sight or Medicare Advantage contracts already in place and have explored or currently with Medicare Shared Savings or ACO Reach or direct contracting, but haven't seen the full potential or recognized the full potential, whether that's from a network preservation perspective, focused on keeping that network together, whether that's shared savings, haven't hit the shared savings that they feel that they deserve, or have aligned with the amount of investment that they've put into place. And I would certainly see strong fit with those organizations that see progressive views on team-based approaches to care and utilizing all sorts of backgrounds in the delivery of primary care services, and are open to those sorts of partnerships that allow their patients to have a stronger relationship with the primary care physician, but also with the practice as a whole, as we operationalize team-based care.
Fantastic. So we're going to turn it over to our panel now. They're going to ask you some harder questions to see, where UpStream would fit. But this is a really important philosophy, is that if you're a senior leader, whether you're a chief information officer, chief clinical officer, chief executive officer, chief financial officer, you want to work with partners that are ready to work with you, right? And so you want to make sure that you select those best. And you heard a lot from Mark on what he learned from his time over at CMS, what brought him over into UpStream. And there's a lot of value here. So we look forward to connecting with the rest of the panel and continuing this conversation. Thank you, Mark, so much for getting us started on this value-based care discussion. We learned a lot about how, if you have the right data, you can take more risk and do things like prepayment, and that if you don't have all that data and don't have all that integration, you can't really move to value-based care. And so with that, I'd love to introduce Robert Groves. Robert and I have known each other for a little while, and I found so much wisdom in his words that we love just having him on to kind of like expand our thinking, especially when we're talking about innovation in networks, innovation in delivery connected with payments. Robert works at Banner Aetna, which is a joint venture between Banner Health, which is a care delivery organization, and Aetna, which most of you know is a payer. Aetna, of course, was recently acquired by CVS, and so he's connected now with that as well. Robert, tell us a little bit about yourself and what you do at Aetna, and what is this thing, Banner Aetna? What does it mean to the industry?
Sure. Thanks, Shahid. It's good to be here. I started my career as a pulmonary critical care doc, practicing actively in the hospital and in the clinic, and did that for many years. And then around 2005 was recruited to Banner Health, where I spent over a dozen years. I was initially recruited to roll out something called the EICU or tele-ICU. And I've always been interested in the intersection between healthcare and technology, so it was a good fit for me. I stayed with Banner and did various other functions over the years, culminating in vice presidency of health management, as we called it, and the chief medical officer for the Banner Health Network, which was part of the insurance division at Banner Health. And it was through that role that I learned about the joint venture that was being planned between Banner and Aetna. And so I jumped at the chance to try my hand on the payer side, and moved over to the payer side 5 years ago as the executive vice president and chief medical officer for Banner Aetna, this joint venture that you just briefly described. And the way it works is it's an independently licensed insurer in the state of Arizona. We are primarily a commercial insurer now, though we just entered the individual market in the last year. And we're obviously interested in getting further into Medicare as well. But today we are the fastest growing commercial insurer in the state of Arizona. And we pride ourselves on trying new things, on bringing innovation into the market to try and transform the way care is delivered in Arizona, and by influence everywhere else we have members.
Yeah, what I loved about what the Banner Aetna joint venture represents is that understanding that you can't actually pull off care delivery innovation by itself. You can't actually pull off payer innovation by itself. You got to put them together, which would seem like, Captain Obvious, saying that, of course, payment models have to be aligned properly with incentive models at the care delivery. But to put your money where your mouth is, which is what the Banner Aetna joint venture has done, is fantastic. And I think the industry can learn a lot from there. What are a couple of the key challenges that you guys are working on from an opportunities perspective over the next few years to say, look, if we just did X, Y, and Z, this venture would mean something to its membership participants in the membership networks, both on the care delivery side as well as the patient side. So what are the top priorities you're looking at?
Yeah, you know, when we were formed, we had a session where we all got together, and basically what we said was, look, even if this is financially successful as a company, even if we both make money, but we don't actually improve care, we don't actually improve the experience of being a member or a patient, then we will have failed. And so our goal is essentially the quadruple aim: to make it fun to be a healthcare provider again, to make it easy to be a healthcare patient, to navigate the complexity of our current system. And by aligning the incentives of both the delivery system and the payer, we hope to facilitate that process or supercharge that process to get there more quickly. Our focus, even starting before the pandemic, was on two specific areas that have really come to the fore recently in this country. And one of them is the scourge of metabolic disease. You know, when you look at metabolic syndrome and obesity and prediabetes and diabetes, it affects about 60% of the population. That's a staggering statistic. And diabetes alone affects 1 in 10. I'm talking about type 2 primarily here. So we wanted to focus on that aspect. You know, what do we do to actually improve the health of our population with regards to metabolic derangements that have become so rampant? And then the second is around behavioral health. And this was pre-pandemic. It's only, you know, the pandemic has only reinforced the necessity of focusing in that area as well. So those are the two areas clinically that we're intensely focused on going forward. But the other piece of the puzzle is we want to make it easier for docs to do business with us. We want to make it easier for patients to do business with us, so people don't avoid care and doctors don't avoid doing things that they really want to do because there's just too much hassle involved. So it is a complex equation that we're trying to solve, but we're very committed to staying the course and persevering to see real improvement in population health in Arizona.
Yeah, and I think one thing that you guys have done really well is organizing the way you think about innovation beyond tools and technologies and into the actual part of healthcare innovation. You know, I quote you all the time when you say you've said that the only way to improve the population health is to improve health of a population. Again, sounds very obvious, but it's very difficult to get people to understand that, look, unless you actually can show less diabetes, less cancer, less XYZ, you haven't actually innovated on the care delivery side. So with that, Mark, I'd love for you to comment on the following. You've heard what Robert is talking about, what they're doing at Aetna. You can talk about that either from your days at CMS or what you guys are doing at UpStream. But it seems to me that we have to separate this idea that care delivery innovation is the same as using innovative solutions in care delivery. So for example, if you haven't changed how you incentivize or pay your physicians, you haven't changed the patient experience, but then you try to bring in quote point solutions or little accessories on top of your EHR, is that good enough? I mean, there's nothing wrong with that level of innovation. Some people absolutely need it, and we don't want to poo-poo that. But if you could figure out, first, what were you trying to accomplish with your care delivery innovation? And then said, let me select the technologies that would help me with that care delivery innovation, I would imagine that would work better. Is that the way you guys were thinking about it at CMS and how you're thinking about it at UpStream?
Shahid, it's a good question. It's a good point. And I look at a few factors here recently that are driving. Recently, we've been digging into physician wellness and physician burnout. We see 42% of physicians currently reporting burnout. In the nursing population, it's 34 to 37%. So these are staggering results, even amidst a great resignation happening across the country. And when we start to uncover some of those drivers, could it be that all of these point solutions were implemented without core restructuring of the payment model? Could it be that we implemented this point of care clinical decision support, which was the hot button topic 5 or 10 years ago to help physicians make better decisions. But it was that without any sort of payment or incentive changes or additional staff in the clinic. We added on telemedicine in a world where the reimbursement wasn't quite perfect 3 or 4 years ago and still has some opportunities for improvement today. So we added all of the system components, but we didn't change the underlying operating structure. And so I think when we start to unpack the root causes here of physician burnout and physician wellness, especially in ACOs and other full risk structures, we have to look at what's actually happening from a payment and incentive perspective. You know, if you look at the HCP LAN, the Learning Action Network, which is that joint private-public partnership between CMS and some of the largest payers and provider organizations in the country, they track on an annual basis what's happening as far as the total percentage of dollars in the United States that flow through a value-based care structure. It's been steadily increasing, which I think we should all be very optimistic about. It's at 40.9% of all dollars in the United States are flowing through a Category 3 or a Category 4 advanced alternative payment model. But we were having a conversation right before we hit the record button on this with Robert, and he mentioned that still, I think it's 5 or 9% of physicians are compensated in a way that's aligned with that value-based care structure. And so when you have this overall global payment innovation, but it's not yet filtered down to the physicians and the frontline providers, I think it can be a very challenging environment to exist in. So what we've been doing recently at UpStream, embedding clinical teams into the practices so they have a base level of support. So you know that you have a trusted level of support that you can rely on for quality gap closures and such. And it allows you to have those arms into the community. We've seen some great promise and great success with physician engagement on that front when they know that they have those appropriate supports. But it's not just the clinical supports, it's the technology and the financial. So the technology piece, we have to figure out which point solutions, but how do we pull all of those together so that we have the right data to drive our decision making at the point of care. We use predictive analytics and AI for that function, but it's taking that to the next level of how do we use predictive analytics at the point of care to select which care partner is most appropriate for that patient, which type of outreach is most appropriate. And then on the financial, we have to tie all of this together as a foundation for incentives that power that holistic view of patient health. And it's not this time-based encounter. It's not the encounter-based fee-for-service system. It has to be global accountability for outcomes. And I think, an unanswered question that I might kick back to Robert here is how do we start to create better measures of outcomes in this environment? Because certainly we have proxies for this. We look at controlling blood pressure. We look at the diabetes A1C under 9 measures. We look at some others around medication adherence that go significantly higher when you embed pharmacists, when you use adherence packaging, those sorts of things. But as a country, how do we start to move forward? And maybe there's some thoughts you'd love to share here around measuring outcomes and tying outcomes to reimbursement.
Go ahead, Robert. Good question.
Yeah, incentives matter. They matter a lot, but they're also they can be challenging, right? I mean, we know, for example, that readmission penalties can have adverse influence on certain populations of patients, for example, in heart failure, as opposed to MI, where it works pretty well for certain diagnoses and not for others. So it's a great question, and it's one that I think we all are struggling to answer. But I do have an example of where we need to think about modernizing the way that we think about, for example, diabetes. It's all well and good to say, look, I want to be able to get your A1C under control. But we also now know that it's possible to not only reduce that A1C, but with a structured program with the right tools, we can actually reverse that process and de-prescribe medications. So, there ought to be some reward for physicians who are willing to, step over that line and say, you know what, it is possible to reverse that what we were previously taught as an inexorable decline in diabetes. And, I think in the coming decade, we're going to see a variety of chronic progressive illnesses that we're going to discover with the right interventions that process can actually be reversed. We can push the clock back on some of these illnesses. And we ought to think about rewarding, at least in those areas where we today know that's possible, rewarding docs for taking that step and offering those programs to their patients, becoming skilled themselves at being in touch with their patients on a frequent basis, either personally or through their teams, so that any patient, anytime, can send a text message and get a response to a critical question that they may have at a point in time where they're ready to make a decision. If you look at the oncology care model, if you look at what companies like Virta Health are doing, that strategy of continuous remote care, I think measuring some of the process tools that we use is also, or could also be part of the equation of metrics that are meaningful for real change in healthcare.
Yeah, and for both of you, we don't really have, unfortunately, in American healthcare, there is no business model for doing the right thing, right? There are only business models for doing what is expected by payers and employers, et cetera, which is not always the right thing. And I think, Robert, you pointed that out very clearly, which is getting somebody off a med would be generally considered lowering utilization and adherence to medication, which is the opposite of what everybody's incented to do. So from your perspective, Mark, just think back at your CMS days. What would you say to someone if CMS put out metrics that say your job is to get people off of medications and not adhering to more medications? What would that look like? And then, Robert, I'd love for you to kind of comment on that and say, well, look, unless CMS and CMMI and others start to reward or ask us to get people off of meds, how the heck are we going to get them off the meds from the payer and the employer side? Because they're all tying to the evidence that you're talking about. Like you said, the evidence is in the CMS websites, but there's a massive fundamental problem here, because the innovation here is getting somebody off a med sometimes, but that is not what we're focused on. So Mark, I'd love to hear your thoughts, and then to Robert.
So Shahid, the good answer to your question is the train is already moving in that direction. We've got some positive movements towards social risk adjustment. I think there have been some interesting activities and developments recently, starting with the ACO REACH model, which is the CMS new payment model related to primary care. It's the retooled version of direct contracting, which is a model that allows primary care physicians and ACOs to take on full risk for a population of seniors over the age of 65. And what we saw with that update from CMS is a focus on payment changes based on an area deprivation index, which measures the factors that go into health related to the community in which someone resides. And so if a particular provider is caring for a population of patients and they live in a historically underserved population as measured by that area deprivation index, then their reimbursement would change in a positive direction. And I think this is the first step, and it's an important signal beyond just the finances that there are factors that are upstream of our outcomes that drive those things that are downstream, such as diabetes, high blood pressure, even cancer. And so as we start to move toward this direction, I think we have to continue to ask ourselves, what is the financial structure that we're operating under? And if it's moving in a direction towards social risk adjustment, where we're adjusting our finances and the payment model above us based on certain factors there, then it takes us down to what is within our control and how do we deliver our services differently. And then that's where I think analytics and technology is important, where we can start to uncover some of those drivers. I think it's incredible work that Robert's mentioning around reversing diabetes. I think it builds off of the work of the CDC's diabetes prevention program, but taking that to the next level across different chronic disease settings to be able to do that. But it all has to be coordinated well, so that, as we mentioned at the start of all this, there's a continuous operating system that has physicians as engaged partners and architects of that system, not just managing the influx of what we're calling inbox medicine these days.
Yeah, and Robert, as you think about what Mark just said, obviously he's not at CMS now, but many of his colleagues will be listening to these kinds of conversations. What would you say, somebody at your level working with major organizations, what would you guys want to come from regulatory to help you with your true care delivery innovations. Because, and by the way, you're welcome to kind of like add on to the remark that Mark made, which is reminding us that only something like 9% of current primary care physicians are properly paid through something not fee for service, right, or RVUs. They're paid by some value-based care. So at the institutional level, it might be 50% of dollars, but who cares if it doesn't get, if that institutional level dollars doesn't make its way down to a physician like yourself? Does it even matter? So you can kind of comment on that and then tell us, what would you want to come from CMS and other regulatory bodies to help you with true care delivery innovation?
Yeah, we have to care what CMS does. I mean, the government is now responsible for over half of the, 3 and I don't know if it's approaching 4 trillion this year or not, but it's getting close to that number. That's a whole lot of money. And so, if half of that is government organized, then what CMS does has profound implications for all of us. And so I do think that the directions that Mark described are the correct way to go. I guess my plea would be, let's move as quickly as possible, because the most dangerous place for our healthcare system to be is in limbo. And that's where we are right now, and that's where we've been for quite some time. And an illustration of that is what you just mentioned, Shad, is the notion that half of payments may be value-based at the system level, meaning large integrated delivery systems or large less typical in physician-led multi-specialty practices. But the payments there may be value-based, but when you get down to the level of the physician, the study recently in JAMA that was a combination of Rand and Harvard doing this, they found that half of physicians today are employed by large integrated delivery systems, hospital companies. And those physicians still 90+% are paid based on volume, either fee-for-service outright or RVU-based compensation. And only 9% of the income of primary care physicians and only around 5% of income for specialists is based on value. Well, clearly that's not going to change behavior at that level. There is still the notion that, you need to do more. So that's the disconnect, is between the system and the way the docs are actually compensated. What I like about what you're doing, Mark, you mentioned this earlier, is real-time payments to the physician. I mean, it's one thing to say, well, if you do all these things well, at the end of the year, there's going to be a little extra for you. It's another thing to every month see the results of your efforts and be rewarded for those. The other thing that I would suggest is that it is the right direction to move towards interoperability and transparency. I mean, one of the things that holds us back, I think, in the healthcare industry in general is that it's not a real market. As long as there are all these opaque areas and issues that are not public knowledge, as long as I have no idea what it's going to cost me when I try to look for a healthcare service, we won't have a market and we won't have real competition. So I think there are a lot of things that CMS can do to actually drive us in the right direction. And I think we're headed in the right direction. The question is, how quickly can we get there? And can we get there fast enough to avoid a real crisis? The other thing that I think is important to uncover is that more and more social dollars, the social safety net, is coming from healthcare. Now, whether or not that's the correct way to think about it is an entirely, maybe another whole show, but it's as if healthcare is taking over what has been a community responsibility. You see folks like Mount Sinai, New York, buying hotel rooms for patients because it's cheaper than boarding them in the hospital when they're homeless and their wounds need to heal. So it's interesting that we see it moving in that direction, but healthcare in many ways is simply a reflection of our society. And so we need to reorganize our priorities. If we really want a healthier society, we've got to get, and pardon the term here, upstream significantly to get in front of some of these chronic illnesses before they become a problem. And that really means health equity is important, access is important, and to some extent, we've got to have a better way to cover everybody so that they're not worried about going bankrupt if they show up in an emergency room.
Yeah, I love the way you summarize that. And in fact, Mark, if you think about what you're doing at UpStream from a managed services organization or MSO perspective, talk a little bit about what would a Uber charged, supercharged MSO do from a benefits perspective to the industry in limbo, as Robert is talking about. So the industry is in limbo because you have legacy players with fixed costs. They can't just change that. You have these brand new upstarts, for a minute, I won't put UpStream in there, but you have upstarts that are focusing on primary care, et cetera, but they have no legacy, so they can do all kinds of new things, but they're tiny. So they can't really move the needle being tiny. So you've got this massive problem, right? The brand new guys up here, legacy guys over here. Could this be a role for the MSOs to say, look, MSOs can move faster, change quicker because they're not looking at massive assets that they have to move around? Or is there some other way to use some newer organizations like MSOs to fill this gap and get us out of a limbo that maybe CMS can't do anything about, because all of what they do requires often acts of Congress, and we know how hard it is to get acts of Congress passed through Congress these days. So what's the role of MSOs today? And Robert, I'd love for you to chime in on that as well. Go ahead, Mark.
Healthcare is fundamentally, and I believe will always be, one-on-one human interactions. It's centered in the relationship and the trust that you place in your provider team, whether it's physicians, other care providers that you encounter. And as we look at that landscape, Shahid, that you laid out, we have the large health systems, we have these small clinic startups. I think what we have to realize is those hundreds of thousands of primary care physicians are scattered all across the country, some employed by large health systems, some independent. And how do we use those primary care physicians as a groundswell movement to be able to change the way healthcare is delivered? I think disruption is probably overused, and as we were mentioning earlier, it's perhaps that's one of the reasons why physician burnout is so high and healthcare provider burnout. It's because we keep disrupting without providing those good solutions, that core fundamental foundation for care. But I think the middle ground here is recognizing that these trusted relationships are built in every community in the United States. And if we can leverage those primary care physicians and their relationships with their patients to be able to build a movement that rethinks how we utilize acute care services, how we go into the home, how we understand the role of community in chronic disease burden in the U.S. And we do that with a financial construct that makes sense. And for us at UpStream, it's a physician compensation model that involves what Robert was alluding to, the guaranteed advance payments for quality. So we actually provide a monthly incentive based on quality measures that roll in on a near real-time basis. And we see that as a guiding force for the physicians to be able to focus directly on quality and then embedding a clinical team around them. But I think that at its core, it's recognized the importance of primary care. I think this is finally a period in the U.S. healthcare system where primary care is in the limelight. And now it's just a question of what do we do with this moment.
Yeah. And the last couple of minutes that we have, Robert, I'd love for you to extend on what Mark just said and say, is there a place for some new types of MSOs that could fill this gap and get us out of the limbo that you've already warned us about, especially given where you are at Banner Aetna? You have a care delivery plus a payer component. So in theory, you have some level of influence and control of some combinations of that. But on the ground, day-to-day patient care is still hard work done by lots of clinics and lots of practices in the field. what could you help with as far as those organizations that are doing the actual care delivery? What kind of managed services might be useful for them that could help them do their job in the way that Banner Aetna would like to see as far as expectations are concerned?
Well, yeah, certainly an MSO can be hugely helpful, particularly to those roughly 30% of physicians who are still very independent. And if you talk to physicians who have become part of larger hospital systems, they're not at all convinced that it's a great idea. They've just thrown up their hands and said, this is too complex for me to manage anymore. And the solutions that Mark is talking about are, hey, let us come in and provide you with that expertise. We understand predictive analytics. We understand artificial intelligence. And what we desperately need is knowledge management in healthcare. The knowledge base doubles in months now. And so having AI to help us manage all of that, you can take it down to something as simple as prior authorization. If as a physician, I had in front of me what's required for this plan in this circumstance, I'm going to have a very different conversation with the patient, particularly if there are references to tell me why this is prior auth. What should I be thinking based on the evidence? If I had that sort of real-time information, I'm having a much different conversation. I'm not putting the relationship at risk. The other thing I want to double down on that Mark said, this is about relationships. And one of the reasons that physicians burn out is we have taken from them the one thing that made this an incredibly rewarding career, and that's the relationship with the patient. You can't do that in 10 minutes as you're on that treadmill based on resource relative value units or fee for service. If you're on that treadmill just trying to keep up, there's no time to actually develop a relationship, understand what drives a patient, and through that relationship of trust, influence them. So to the extent that that an MSO can bring tools that make it easier for me to do the back office part of my job so that I can focus on the relationship part of my job, which is the only thing that will ever influence behavior. It's through those relationships. We have to have time to do that. And if the tools allow us that time, most physicians will self-manage. You give them the right data, you show them how they're doing compared to their peers. You don't even have to unblind it, just show them where they rank. We are motivated. We want to be the best. If somebody down the street is getting much better outcomes at half the cost, I'm going to be going down the street and asking, what are you doing? I want to do it too, because I bet you I can do it better than you can. So that's what we need to unleash, is that natural tendency that physicians have to want to develop relationships with patients, to want to influence them towards health. That intrinsic motivation is equally as important, if not more so, than the financial motivations we've been talking about.
No, I love it. And that's a fantastic call to arms, a great way to summarize what we were talking about. And that is what you've learned from both Mark and Robert here is innovate on the care delivery side. Like, what is it that you want to do for the impact to the patient's lives? And a great example is reversal of diabetes is the innovation, not the SMS messages you're using to talk about the reversal of diabetes, right? That is our core lesson that we can learn from both of these gentlemen here. And the more that we organize, especially at the C-suite level, around care delivery innovation, rather than just using innovations for the delivery of care, that would allow us to then reorganize and pick the right tools and technologies. We need them. We are behind in many cases versus other industries. But if we just pick tools without focusing on the care delivery innovation itself, we're going to get stuck in this limbo, as Robert has mentioned a couple of times here. So that was fantastic advice. Love this conversation. And hopefully you have a lot of follow-up questions as well coming in through the audience. With that, I wanted to thank Robert from Banner Aetna, Mark from UpStream, and I'll let you say goodbye to the audience.
Thank you. Been a pleasure.
Thank you so much.
All right. Fantastic. Thanks all.